Let's read important topic, that is HIV in oncology. So first we must know about HIV. This HIV is not AIDS. AIDS is a clinical presentation, clinical spectrum of uncontrolled HIV infection leading to damage of immune system, and further the damage leads to AIDS, that is, these are disease symptoms. So HIV, a person need not be directly be labeled as AIDS. AIDS is a clinical manifestation of HIV. Now coming to what treatment we have for HIV. See, the drugs are important, basically the group of drug. NRTIs, that is tenofovir, lamivudine, and NRTIs as efavirenz. So this NRTI is nucleoside reverse transcriptase inhibitor, and this is non-nucleotide reverse transcriptase inhibitor. Then the third group is protease inhibitor, also known as PI, that is lopinavir. Then the fourth is INSTI, which is integrase strand transfer inhibitor. These all are various steps of replication in HIV. Now INSTI, the dolutegravir, this is there. Our famous zidovudine is here, zidovudine NRTI. So these are the common group, and the common schema is 2 NRTI plus 1 INSTI, but it can be in any combination. The PI, the NRTI, so basically 2 to 3 drug combinations are there. Now when we are discussing patient with HIV of written PWH, they have peculiar thing about HIV therapy. So the drug interaction, the drug to drug interaction is important. So the interaction, if you look, mainly interaction is cytochrome P450, either inducer or inhibitor, leading to toxicity or decreased activity. So this protease inhibitor, if you look, protease inhibitor are inhibiting this cytochrome P450, thus the toxicity will increase chemotoxicity. So protease inhibitor giving with vincristine increase neuropathy, giving with alkylators, taxanes increase myelosuppression, then alkylators increase myelosuppression. So protease inhibitor is actually causing enhanced side effect. Now if you look for CYP450 inducers are NNRTI. When you look back, this non-nucleoside reverse transcriptase inhibitor efavirenz is efavirenz and is there. So efavirenz is NNRTI. It induces cytochrome P450, so it decreases chemo effect. Not only chemo, the azoles, cardiac medicine, they all need consideration of cytochrome P450. So now this says that protease inhibitor is not a good group because it has lot of interaction. When we are using NNRTI, you should use caution because it can decrease the effect. So that's the thing you must remember while planning the chemotherapy. Moreover, this NNRTI is also increasing hepatotoxicity with chemo. When given with chemo, hepatotoxicity chances increase. So, as a principle, we want to avoid zidovudine also. We want, because that's a quite myelosuppressive effect is enhanced. We want to avoid protease inhibitor also. In NNRTI, we want caution. So, which drug is the most safe? Most safe is INSTI. So, this integrase strength transfer inhibitor, dolutegravir, is this group is most preferred. Now, there is never a single agent. So, the preferred agent is dolutegravir along with NNRTI, tenofovir plus lamivudine plus dolutegravir. So, what we are using is NRTI, INSTI. So, this is safer a combination of used with the chemotherapy because having low drug interaction. What we want to avoid is PI and NNRTI. So, PI and NRTI we want to avoid. And apart from that, from NRTI group, the zidovudine is avoided due to myelotoxicity. And that preference interaction with the chemo and the side effect management need involvement of pharmacologist in the planning of care. So with this information, there are some principles of care in HIV and oncology. So this is quite useful. If we remember this, it can be put in any of the disease, any of the oncological condition. So the first is start ART to all patients. All patients, obviously HIV positive with cancer. So in normal population, ART criteria are there based on CD4 count. But start ART to every PWH with oncology. Prefer INSTI based ART. Avoid protease inhibitor. Avoid zidovudine. Then watch for cytochrome P450 interactions both from the drug of HIV as well as from the chemo and supportive care. Start preferably 7 days before starting chemo. So give ART for 7 days, then start chemo. But suppose both need to be started simultaneously, one should be cautious or delay for 10 to 14 days. So toxicity and this toxicity profile should be avoided, overlapping toxicity. But sometime like DLBCL is there, you cannot wait, high risk DLBCL. And this from AIDS side, if leukoencephalopathic changes are there, then one cannot wait for HIV treatment also. So there are conditions in both can be started, but preferably give HIV treatment for 7 days. That will lower down the viral count and then start the cancer-directed therapy, chemotherapy especially. Now, treatment of cancer as per standard. So there is no rationale of compromising chemotherapy, immunotherapy, targeted therapy in HIV. So as per the standard guidelines, do the chemotherapy, do the radiation, do the surgery. While we are making note of that HIV has higher chance of mucositis, gut inflammation. So in radiation field, you wish to avoid that mucosal surface or the intestine. But otherwise, whatever standard is there, do that standard. So even immune checkpoint inhibitor, use as per standard. Okay. Whenever we are using immune checkpoint inhibitor, there are two things to remember. That this Kaposi sarcoma virus, if positive, it can reactivate, can cause two syndromes. One is multicentric Castleman disease So a generalized progressive lymphadenopathy starts just after giving immunotherapy in few weeks. So one should do the biopsy to see whether multicentric Castleman has started or not. They need separate treatment. Then is KICS, KICS, that is Kaposi sarcoma virus associated with inflammatory cytokine storm or syndrome. So this again, high grade fever, progressive lymphadenopathy, systemic feature. So one should look for these two whenever we are using ICI in AIDS cases. Now, but ICI as per standard guideline can be used. GCSF to all chemo. Even the chemo with low propensity of neutropenia, the happening of neutropenia is not good because the CD4 count might be low. So it's always advisable to use GCSF prophylaxis in all sort of chemotherapy. Okay, and then ECOG-PS performance status. It may be poor due to cancer, due to HIV. So treat cancer as well as HIV rather than saying that poor PS is there. If PS is due to cardiac and other element, he is not fit, then otherwise treat them. And the last point is always check tuberculosis before starting chemo because chances of reactivation is very high. One more important point is that every disease may not be cancer. So always do biopsy. So suppose a node is there, brain mets looking like lesion is there. The node might be tuberculosis, the brain lesion might be toxoplasmosis. So always do the biopsy in HIV setting rather than assuming that primary is there and this is metastatic lesion. So these principles, while we are discussing the diseases, we are always coming back to see, and this holds true for almost all disease. Now coming to why HIV as cancer. So there is association of HIV. It increases almost all type of cancer chances. So HIV causes immune dysregulation. HIV causes inflammation. A chronic inflammatory state is there, and it increases oncogenic virus infection like HPV, this HHV8, EBV. These all three leads to oncogenesis. So that's how HIV is increasing the chances of cancer. So there are few historical terms. One historical term is AIDS defining malignancy or AIDS defining cancer. Earlier it was like if these cancers are present in HIV, this is defining that AIDS is there. Already HIV is in advanced stage. Moreover, it was a clear association noted earlier, but they need a treatment, they need a biopsy, they need everything. So the wrong notion that in HIV, if there is a cervical lesion, it is defined by HIV. It's not like that. So it's a historical term. Only 3 diseases can be remembered like KCL were included: Kaposi sarcoma, cervical cancer, and lymphoma, in which it is B cell lymphoma, B cell NHL only. So these AIDS defining malignancy, then AIDS or HIV associated malignancy. Associated cancers are many. Anal cancer, quite commonly associated. All perineal cancer, perineal area cancer. So this anal, cervical is defining, vulvar, penile. These all cancers are associated with HIV. Then non-small cell lung cancer, Hodgkin lymphoma, HCC. These all are clearly associated with HIV. The incidences increases to some cancers 2 to 5-fold, something more than that. So the third thing, HIV increases chance of pre-malignant lesion. Increase conversion of pre-malignant to malignant lesion. So these three things we must remember while dealing with HIV in oncology. Okay, so let's start fitting the information into separate cancer types. Okay, so the first, let's see about anal canal. It has two things: dysplasia, that is pre-malignant condition, and CA anal canal, that is full-fledged malignancy. So looking at dysplasia, the risk of dysplasia increases in patient with HIV. Always screen anal canal in any perineal cancer, let it be cervix, vulva, penis, vagina. Always screen anal canal. Always screen perineal area in CA anal canal. Both ways are there. So if you are getting dysplasia or malignancy of anal canal in PWH, that is person with this HIV, screen vulva, vagina, penis, look for the malignancy, cervix. So when to screen the anal canal, all patient with HIV more than 45 years of age, screening is recommended. But high risk population, high risk PWH, that is male having sex with male, a receptive transgender woman, again a receptive partner. So the screening can be preponed by 10 years. How we are going to do screening? So screening is anal cytology, HPV DNA testing. It's like cervical screening, and digital anorectum examination, also known as digital anorectum dare. So this anal cytology, what expected result we can get? It may be normal. Okay, so usual follow-up. It may be HCL, high-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion. Same like it is happening in cervical cancer, it can be low-grade squamous intraepithelial lesion. It can be ASCUS, unknown significance, atypical squamous cell width of unknown significance, or any abnormal finding on DARE, that is digital rectal examination. If anything is there, you go for high resolution anoscopy to confirm the dysplasia. Okay, if even with low high HPV DNA is positive, again the indication is to go for high resolution anoscopy. It is going similar to the cervical cancer when we are doing colposcopy. So if we find that dysplasia, what is the treatment? So if everything is normal, put back to the annual follow-up. If not normal, dysplasia is there, the treatment is topical treatment, that is putting 5-FU topically, imiquimod topically, or we can do excision, ablation, electrical excision, electrocautery, that is high fraction. This is preferred. Electric excision. So you remove the lesion, dysplasia lesion, and consider HPV vaccination also based on HPV DNA testing. Despite that, the risk of recurrence, risk of transition to CA cancer is high in patient with HIV. So that's about dysplasia. So the crux is the risk is increased. The crux is do early screening. If anything doubt, treat it. But despite that, the risk is there. Now, if we look for the treatment, treatment of anal canal cancer. So first look for the perineal organs for other dysplasia and cancer, vagina, vulva, cervix, penis, everything. Now treatment, we are back with the principle of treatment what we discussed. So look at principle of treatment. So go back to principle of treatment, how we are going to treat. So start ART to all the patient, preferably 7 days before. Okay, prefer INSTI based. Start 7 days before, treat as per standard. So whatever protocol of radiotherapy along with mitomycin and 5-FU is there, the usual protocol of anal canal is that if the lesion is very small and away from covering less than less than 1/3 of the circumference and the preservation of sphincter is possible, local surgery, otherwise CTRT with mitomycin and 5-FU at the onset and at the last of the RT. So this standard to be maintained here also as per the standard rate. Okay, then give this GCSF after the CTRT chemotherapy part, and if by chance there is a recurrence, immunotherapy comes in, the pembrolizumab data is there, use that with a caution about this MCD, multicentric Kesselman and KICS. Now performance status, again look, it is maybe due to anal canal cancer or HIV, treat. Check TB before starting this and monitor this CD4 plus count. Okay, apart from these there are many other things, so we'll adhere all them. So prophylaxis is very important. What prophylaxis? So if neutropenia is there, then antibacterial, so fluoxacin, levoflox, ciplox, this prophylaxis. PCP prophylaxis, very important. So Bactrim DS. Fungal prophylaxis is important. So azoles having more reaction if fund is not an issue. Posaconazole preferred, otherwise fluconazole. Then we have viral prophylaxis. So acyclovir 400 mg BD or valacyclovir. So these prophylaxis will also go in all these along with CD4 plus monitoring. So this is the treatment of CA anal canal. So the usual treatment with HIV directed treatment with drug to drug interaction consideration with prophylaxis, that's it, and check for the tuberculosis or other infection. So main difference comes for the dysplasia. That is a lengthy difference, but the basic difference is early screening and the chances of recurrence and progression is high. So look for the principle of treatment, treat as standard, check for TB, other infections, chronic infection, then ART to continue, drug to drug interaction need a review by HIV expert as well as oncologist, so the team should be there. Then prophylaxis, so GCSF for all chemo and prophylaxis, antibacterial, antifungal, anti-PCP and antiviral, also to prophylaxis. So standard treatment. Now coming to the other disease, we have cervix. Again cervix has two parts, dysplasia and CA cervix. Now look at the dysplasia. It's like anal canal dysplasia. The incidence is increased in patient with HIV. Look for all perineal organ. There is vulva, vagina, penis, cervix is there, vulva, vagina, anal canal. So perineal organs should be screened. Now screening for a normal person with HIV, the screening protocol is 21 year onward by cytology. More than 25 years, co-testing with HPV DNA. But this HPV DNA is a common finding common finding till 30-year age. So it is hard to act on that unless there is cytological abnormality. So if dysplasia is present on cytology and HPV is also present, go for colposcopy. If no dysplasia and HPV present in age group 25 to 30, repeat cytology in 6 months to check whether dysplasia is coming or not. So more than 30 HPV positive is more than 30 year HPV positive, we can go for colposcopy directly. Now if dysplasia and HPV positivity get or dysplasia is there, what result we can have? We can have ASCUS, atypical squamous cell of unknown significance. We can have low grade squamous intraepithelial lesion, high grade squamous intraepithelial lesion. So these all ultimately we have to go for colposcopy. Colposcopy and direct visualization under applying acetone or this iodine. So look for that area, do the biopsy, okay, or excision. That's the usual procedure. So that treatment is there for all type of dysplasia. Go for colposcopic, excise it. So the excision is preferred. Now loop excision is less preferred. Complete excision is more preferred, especially for HSIL. Loop excision less preferred. So excision, complete excision is there. There is no local therapy like see anal canal, that 5-FU and imicodone is there. It is not there in CA cervix. Despite all, risk of recurrence and risk of progression is there. Progression to CA cervix is there. So yearly follow-up with colposcopy is required. Now coming to treatment of CA cervix. Again, same, we should go back to the principle of treatment. Look for all the principle applied here. So HIV treatment to start or to continue. Okay. Then check for latent infection, that is TB or other toxoplasma. Then standard treatment for CA cervix to be given. The CTRT, if advanced state, the immunotherapy can, ICI is also okay. So based on stage, the FICI we are giving, we have to look for multicentric Castleman disease and KICS, that is Kaposi sarcoma virus induced associated inflammatory cytokine storm. And then we have to give GCSF and we have to use prophylaxis for antiviral, antibacterial, antifungal and PCP. So this is the treatment management. The management is not differing apart from these salient point addition. So, and dysplasia, again the screening is important. So if any dysplasia is there, then we need to excise in CA cervix. So that's about CA cervix. Now coming to what else disease we want to look at. So the other association is Hodgkin lymphoma. Now Hodgkin lymphoma, there is no screening protocol. Okay, so this person with hepatitis has 5 to 14 times more risk of Hodgkin lymphoma, and usually the type is mixed cellularity and lymphocyte depleted. So lymphocyte depleted is classically associated. Mixed cellularity you can find otherwise also, and 90% are associated with EBD. So it's an oncogenic virus that is causing this Hodgkin lymphoma. Common to have aggressive disease, B symptoms, bulky disease. These are common finding. So treatment as per standard. What standard we have? We have planning ABVD, go with ABVD, Nivo ABD or brentuximab ABD. All as per the standard can be given safely. Okay, only thing when we are giving Nivo, we need to look for multicentric Castleman disease and KICS as a immune flare up. We should give growth factor although ABBD doesn't require, but it's better to give chemo density can be tweaked. So decrease dose if neutropenia, mucositis happen. See, the principle of HIV chemotherapy is the neutropenic sepsis. Neutropenic period is having increased sepsis risk. Mucosal damage should be minimum. So if keeping this principle, even ABBD dose can be adjusted in subsequent cycle in Hodgkin lymphoma. Otherwise, one prefers dose dense and dose intense ABBD. GCSF is recommended. Then HIV related all prophylaxis must be given. PCP, viral, bacterial, fungal. So bacterial is basically when the counts are low, and monitor CD4 count. So this is the treatment of Hodgkin lymphoma. No other modification is required. And obviously the drug interaction, the team must have HIV pharmacist or HIV expert, and we devise the treatment. Both treatment will go. HIV treatment, this ART as well as this Hodgkin lymphoma treatment. Similarly, if we are looking for other associated non-small cell lung cancer, so the thing is the risk is 2 to 5 times high. Here there is a role of screening. Low dose CT scan. Screening is recommended for smokers for more than 50 years. So that is also recommended for HIV. So it should be slightly younger age in HIV for this lung cancer, but the screening age is not defined. So based on HIV status, how many years, one can start the screening at slightly younger age also. Now, specific thing, nodules must do biopsy. It may be mixed type nodule, it may be infection. Even in Hodgkin lymphoma, all nodes, node recurrence and HIV related problem both can happen. So like this Castleman disease can happen. So any node enlargement must be confirmed by biopsy. Any nodule in lung must be confirmed. Any brain nodule, do not take it like brain mets. Confirm with the biopsy. It may be toxoplasma also. Then the treatment is as per standard. Immunotherapy is in and out in non-small cell. So we must watch for this KICS and MCD. So this is short about HIV in oncology. So main crux is you need to look for the principle of chemotherapy. So again, coming back to the same crux. If you remember this, we can fit this in all type of cancers. So start ART to all patients HIV positive with cancer, irrespective of CD4 count. Prefer INSTI based ART. Avoid protease inhibitor. Avoid zidovudine. Zidovudine is myelotoxic by itself. It will increase myelotoxicity. Watch for cytochrome P450 interactions. So even supportive care, watch for that. Start preferably 7 days before starting chemo. So ART start, or just prefer not to give just on the day, not to start just on the day of chemotherapy. Treat the cancer as per standard. Radiation, take a note that avoid mucosa and avoid gut if possible. Surgery, no change. Chemotherapy, no change. Okay. In chemo, if we are giving immunotherapy, use as per standard. Only watch reactivation of the Kaposi sarcoma virus related, this multicentric Castleman disease, and this KICS, that is Kaposi sarcoma immune virus associated inflammatory cytokine storm or syndrome. Now GCSF to all chemotherapy, because we want to avoid neutropenia and because chances of neutropenia is high. So even for ABVD, GCSF is preferred. Then poor performance status, it may be due to HIV and cancer. So treat. Unless you prove that poor performance status is due to some organ like cardiac, respiratory, where the treatment can be stopped. Check tuberculosis or other opportunistic infection before starting chemotherapy. All PET-avid lesion need biopsy confirmation because HIV itself can have lot of nodular lesion in brain, like toxoplasma in lung, tuberculosis in node like tuberculosis. Prophylaxis goes with the ART, that antibacterial in the low count setting, Leoflox or Ciproflox. Then PCP prophylaxis, the spectrum D is always. Fungal prophylaxis, azoles need to be monitored with cytochrome P450 interaction. Posaconazole preferred, otherwise voriconazole, fluconazole. These are then viral, either acyclovir or valcyclovir. Prophylaxis will go side by side. Frequent monitoring of CD4 count should be there to assess the risk of infection. So This is the modification required, and that's a brief about HIV in oncology.